Tuberculosis. Tuberculosis caused by infection with Mycobacterium tuberculosis may be bovis or humanis. It, there are three types of tuberculosis: primary tuberculosis, secondary, and then miliary tuberculosis. Primary tuberculosis is the initial infection caused by inhaling Mycobacterium tuberculosis. It is often asymptomatic and mild and heals automatically. But if the immune system is compromised, it may progress to active disease or disseminate to other organs. The bacteria typically settle in middle and lower lobe, forming a localized area of inflammation called Ghon's disease. Combination of this lesion and enlarged unilateral hyaline lymph nodes are known as Ghon's complex. Sometimes a small amount of pleuropharin is also present. Secondary tuberculosis, when a dormant mycobacterium tuberculosis infection activates, it typically occurs in the upper lobes of the lungs, where oxygen levels are at the highest. Years after the initial exposure, when the immune system is weakened. In miliary tuberculosis, a widespread severe, severe distribution of tiny millet seeds sized lesions, 2 to 3 millimeter in size throughout the entire body, life-threatening form of disease that occurs when a massive amount of Mycobacterium tuberculosis enters the bloodstream and spreads throughout the body. In secondary tuberculosis includes ill-defined opacities in one or both of the upper lobes, and as it progresses and as progression occurs, consolidation, collapse, and cavitation develop to varying degrees. Occasionally, caseous lymph nodes may drain into an adjoining bronchus, resulting in tuberculous bronchopneumonia. This is primary tuberculosis. Unilateral lymphadenopathy, and this is the primary lesion. Opacity, just a small consolidation subpleuritic, and sometimes there is also pleural effusion, little pleural effusion. This is again primary lesions or Ghon's lesions, and this is the consolidation sub subpleuritic. This lesion subpleuritic, this consolidation, and this adenopathy both are known as Ghon's complex. Typical secondary tuberculosis in the apex of the right lung, scattered opacities in the apex, again secondary tuberculosis in the mid and left upper zone, scattered tuberculosis, scattered opacities in the upper and the mid zone. This is cavitation due to chronic tuberculosis. Multiple cavities on this side, again multiple cavities with thick wall due to chronic tuberculosis. Another cavity on this side, lower zone of right lung, tubercular cavity, thick wall. This is miliary tuberculosis. Small opacity is 2 to 3 millimeter size spread throughout the lung, and this is blood-borne and life-threatening disease. Chronic complications of pulmonary tuberculosis. It may lead to carbonyl, fibrosis or emphysema, atypical mycobacterial infection, lung or pleural calcification, bronchiectasis, bronchopleural fistula, empyema, laryngitis, enteritis, anorectal abscess, amyloidosis, lymphadenitis, pericarditis, meningitis. bone and joint disease, and genitourinary infection. Diagnosis: the sputum is examined for access for bacilli, and second is fluid examination of the pleura. Third is blood CP and ESR. Then tuberculin skin test, culture. There are two types of culture. One is solid and another liquid. Culture, solid culture is Lawrence and Johnson, which gives result from 4 to 6 within 4 to 6 weeks. Liquid culture is through Bactate or MGIT and takes 1 to 3 weeks. Nucleic acid amplification test or skin patch test. Interstitial and inflammatory pulmonary diseases. The diffuse parenchymal lung diseases are a heterogeneous group of conditions affecting the pulmonary interstitium or alveolar lumen. The presentation and natural history of these diseases may differ widely, but they are frequently considered collectively as they share similar symptoms, physical signs, pulmonary function abnormalities, and radiological changes. High resistant computerized tomography has become the first step of investigation. The causes include drug or due to connective tissue disease, idiopathic interstitial pneumonias, sarcoidosis, histiocytosis, organic or inorganic dust, and inorganic gases and fumes. In X-ray, all patients have an abnormal chest X-ray presentation with lower zone bibasal reticular or reticulonodular opacities. A honeycomb appearance may be seen in advanced cases but is non-specific. This is interstitial disease. The lung of a person who works in iron mines, who has worked 6 months in ore mines, and this is pneumoconiosis or cirrhosis. Interstitial disease, a form of interstitial disease. Then primary tumors of the lung. The primary tumors of the lung can be are these bronchogenic carcinoma, arises from the bronchial epithelium or mucous glands. Etiology: is unknown, but the factors which exaggerate or which we promote for the primary tumors are cigarette smoking, exposure to naturally occurring radon, incidence higher in urban than rural areas, atmospheric pollution. This is bronchogenic carcinoma occupying the upper part of the right lung, nearly well defined opacity. There is also slight pleural effusion in the. These are hematomas. There is are hematomas, non-cancerous tumor like malformations, consist of normal cells and tissues native to the organ where it forms, but they grow in disorganized haphazard manner. They are generally harmless and do not require treatment. Hematomas, non-cancerous, benign tumors. This carcinoma of the thyroid, the superior intestine is widened with the secondary in right lung is clearly seen. Complications of carcinoma of the lung. The carcinoma in the lung apex may cause Harrowner syndrome due to involvement of the sympathetic chain. at or above the stellate ganglion, that is Pencas tumor, in which the signs are drooping of the eyelid, pinpoint pupil, and loss of sweating on that side. Second is involvement of the left recurrent laryngeal nerve by the tumor at the left hilum causes vocal cord paralysis. Third is digital clubbing. Then fourth is hypertrophic pulmonary osteoarthropathy. Fifth is non-metabolic extrapulmonary effects. Non-metabolic extrapulmonary effects are inadequate ATH secretion, small cell, and B is ectopic adrenocorticotropic hormone secretion by small cell, and C is hypercalcemia. Radiological presentation is usually irregular but well defined and may be very large with cavitation. It may show lung lobe or segmental collapse, pleural effusion, broadening of the mediastinum, elevation of the hemidiaphragm, rib dissection due to direct invasion or bloodborne metastasis. Secondary tumors of the lung, they usually are multiple and bilateral, and they may arise from breast, the kidneys, the uterus, the ovary, the testis, and thyroid. Secondary lung tumors, multiple rounded opacities are seen on both sides. These are secondary tumors of the lung. Then Echinococcus granulosa, that is heart disease cyst. The eggs are the definite host of the tiny tapeworm. In the larval stage is a heart disease cyst. Normally occurs in the sheep, cattle, camel, and other animals that are infected from contaminated pastures and water by handling a dog or during contaminated water. Humans may ingest eggs. The embryo is liberated from the ova in the small intestine and gains access to the blood vessels and thus thus in liver, mainly right lobe, and rarely in lungs, bone and brain. The resultant cyst grows very slowly, sometimes intermittently. It is composed of an enveloping fibrous pericyst, laminated hyaline membrane, ectocyst, and inner germinal layer, that is endocyst, which gives rise to daughter cyst in which larvae develop over over time, and some cysts may be calcified and become non-viable. The disease is common in Middle East, North and East Africa, Australia and Argentina. These are hydatitis, right lung, well-defined big balloon-like hydatitis, just balloon-like. This is upper and this is lower. And they may be in liver and other tissues as well. But commonly they are present in lungs and liver. This is liver abscess. Now see the diaphragm on left side and see the diaphragm on the right side. There is lot of difference, lot of difference. The diaphragm shifted here because of the pus from the liver. There is no space between the liver and the diaphragm. The lungs in heart disease may show pulmonary venous hypertension or arterial pulmonary hypertension. In pulmonary arterial hypertension may be acute or chronic. Acute pulmonary venous hypertension is seen in left ventricular failure. Chronic is seen in chronic left ventricular failure, mitral stenosis, atrial myxema, and cotriatum. Pulmonary arterial hypertension, post-capillary pulmonary arterial hypertension is seen mostly follows pulmonary venous hypertension and left to right shunts. Pericapillary pulmonary arterial hypertension is due to reversal of the shunts. This is mitral stenosis, typical case of mitral stenosis and venous hypertension, pulmonary venous hypertension. The pulmonary veins are going towards the apex. This is pulmonary venous hypertension. This is the pulmonary conus, prominent pulmonary artery, and this is the left ventricle. This is the left atrium, and then the right ventricle. The double bordering because of enlargement of the left atrium, and then is the left ventricle. This is a case of pulmonary arterial hypertension. This happens is mostly in cases of shunts, ASD, VSD, and PDA. The flow in the right from left to right increases enormously, and here we can see that the thick pulmonary artery, right pulmonary artery, and the pulmonary conus is very prominent. The left pulmonary is also prominent. The right pulmonary artery is very much thickened, very obese. This is typical case of shunts in which the pulmonary arterial pressure is increased, and this is commonly seen in ASD, VSD, and PDA. This is a case of acute intra-alveolar pulmonary edema with a bad swing appearance. This is case of acute myocardial infarction, and this is acute venous hypertension. Acute. The heart size is normal, short history, acute chest pain, acute dyspnea pulmonary edema, and in this the bad swing appearance, the the congestion is seen at the hilar region on both sides, giving it a bad swing appearance. Bad swing appearance. This is pericardial effusion, a globular heart with diminished vascularity on both sides. This is pericardial effusion. Coarctation of aorta. This is the coarctation of the aorta. This is the ascending aorta, widened, seen going up. This is ascending, thickened, widened. This is the coact, and after this is the descending aorta. Another case of coarctation of aorta, and also showing notching of the ribs. Lower ribs are notched, notches in the ribs. They are typical of coarctation of aorta. This is a typical X-ray of pulmonary embolism. A triangular shadow in the lower zone, apex going to the hilum. This is typical case of pulmonary embolism. Thanks for watching.